My name is John Kuo. I'm one of the reproductive endocrinologists, and I'm going to talk about the background and also some screening before in vitro fertilization. So I first want to talk about basic female pelvic anatomy. In this slide, there is the ovary, which contains the oocytes in the eggs, which is usually after ovulation picked up by the fallopian tube where fertilization occurs. The fallopian tube is connected to the uterus. The fetus usually implants in the uterine cavity. And it grows in the uterus. And below that is the cervix, which is attached to the vagina. So this female anatomy sits in the pelvis here in a schematic. And on the right side is a laparoscopic, which is a camera surgery through the belly button, picture of the pelvis. And you see the ovaries in white, and this is the fallopian tube here. And the uterus is not seen on the left side of the picture. So I just want to talk about briefly the basically hypothalamic pituitary ovarian axis. So the ovulation is not controlled by the ovary, it's actually controlled by the brain. So at the base of the brain, there's a hypothalamus, and just below that is a pituitary gland. The hypothalamus releases gonadotropin-releasing hormone to stimulate the pituitary gland to release gonadotropins, which are FSH, follicle-stimulating hormone, and LH, luteinizing hormone. And these two hormones are important because these are the medicines that you will be receiving in vitro fertilization. But normally what happens in the female body is that these hormones travel from the brain through the bloodstream to the ovary, stimulates the ovary and the eggs in the ovary to grow in what's called follicles, and as these follicles get larger, the eggs mature. At the mid-cycle, you have a surge of LH, which triggers the ovulation, which is then picked up by the fallopian tube. Fertilization typically occurs in the fallopian tube and then travels to the uterus to implant. Basically what happens is that with the growth of the ovulation, the estrogen rises, and normally in the body, it feeds back negatively, decreases stimulation, and you only get one egg to ovulate. After ovulation, there's estrogen and progesterone produced to help the lining for implantation. What we do differently with in vitro fertilization is after stimulating, we don't want the female to ovulate. We will insert a needle under anesthesia into the ovary and withdraw the oocytes. The oocytes will be placed in a dish, and they will be inseminated with sperm. And we will let the eggs and sperm meet and grow into embryos. After several days, we will transfer the embryos back into the uterus. So there's a lot of indications for reasons for in vitro fertilization. Some of these include tubal disease or obstruction. So if the sperm can't meet the eggs, you can bypass the tubes with in vitro fertilization. Other causes are severe endometriosis, which is a disorder where the lining of the cavity, which sheds with periods, is now in an abnormal area outside the uterus, and that causes basically bleeding and inflammation within the pelvis during your periods. That can result in a lot of inflammation and scarring, and can be a indication for in vitro fertilization. Other indications are male factor infertility, so abnormal sperm, very low count of sperm. We can bypass and basically inject the sperm directly into the egg. Unexplained infertility is if you have no cause, you can also perform IVF. And we can also determine some of the causes. For instance, you can compare the sperm naturally inseminating into the egg, or you can inject the sperm into the egg and compare the two groups, and you can see what the fertilization is normally if you were doing it naturally. And to see if IVF with intracytoplasmic sperm injection is useful for you. There's also oocyte donation. So if you need an egg donor, you would perform in vitro fertilization. We would take the egg out of the donor and then transfer it into the recipient or the surrogate. Ovulatory dysfunction. If you don't ovulate, you won't have an egg to fertilize, and you can use in vitro fertilization to stimulate eggs and obtain mature eggs. Or if you've tried more conservative treatments and you failed, and this is a more aggressive treatment. So this is an outline of the talk tonight. We're going to talk about pre-screening, some IVF stimulation protocols, the oocyte retrieval and embryo transfer, some of the complications that can occur with in vitro fertilization, some of the results, and specifically what the process is differently with donor oocytes. So for the male, the screening consists of a semen analysis. So basically the male will collect a sample. They'll look at the volume of the ejaculate, the concentration of the sperm, how they're swimming, the motility, or what they look like in terms of size, shape, and proportion, called morphology. In addition, in California, we are mandated to basically obtain infectious disease testing for HIV, hepatitis B, hepatitis C, syphilis, and human T lymphocyte virus. So these are state law that we will draw on the male. So the female screen is a little bit more involved, and the infectious disease panel is very similar. In addition, we do a day 3, or menstrual cycle day 3, FSH and estradiol. This tells us indirectly what the ovarian function is. The FSH is released again by the brain to stimulate the ovaries to grow eggs. So if the FSH value tends to be high, that means the ovarian function tends to be more poor, and vice versa. So you want a low FSH indicating a better ovarian function. So we can also do what's called an antral follicle count. When you get your ultrasound, we will look at the ovaries and count the number of small follicles, and each of these follicles contain an egg. So the higher the antral follicle count, indirectly it tells us you have more eggs in your ovary and you'll respond better to the stimulation. We will also perform a trial transfer, which is basically a practice run where we take a catheter and pretend we have embryos there and basically go through the cervix and enter the uterus to make sure that we don't have any actual difficulties on the actual embryo transfer when we have embryos in there. We don't want to have a struggle. We want to know what the anatomy of the cervix is going to be beforehand. And then lastly, we want to evaluate the uterine cavity. We want to make sure that the uterus has a normal cavity for implantation. And one way we can do that is called a saline sonohystogram. A catheter is inserted through the cervix, and sterile saline is injected into the uterus. So the uterine cavity is a potential space, but if you inject fluid in there, you can actually get a good look and see if there's anything in terms of a polyp or a fibroid that involves a lining and it would affect implantation.